Hello everyone. Today I will be recording a basic introduction to the legal aspect of mental health. We'll go over some fundamental principles such as ethical dilemmas, rights, rules, and regulations, especially while taking care of individuals with mental illness. Please keep in mind that laws and regulations can vary from state to state, but for this session, we'll be focusing on our beautiful state of California.
So the first thing I want to do is, before we really get into rights and regulation, just introduce some terms. The first one is autonomy. So that's a fundamental, principle, right to have autonomy. So it doesn't matter if you have a client with psychiatric illness or not. All of us, all patients in every setting, will enjoy this basic right to autonomy. Now, the next terminology is, or ethical principle is, beneficence. Beneficence is one's duty, to benefit or promote the good of others. So, as a healthcare clinicians, as a healthcare providers, it is our responsibility, duty to benefit, to help somebody. For example, if a client is in pain, if client is in suffering, we intervene. We offer either pharmacological interventions or non-pharmacological interventions, and the idea is to help your patients. Now, the other principle is non-maleficence. So non-maleficence means we as a healthcare providers, we should not harm our clients. Now, look at the difference between beneficence and non-maleficence. Here it says, make sure we help somebody. You promote the good of others. You benefit someone, right? Here it says, do not harm. Now, in my opinion, non-maleficence is far more important than beneficence. What do I mean by that? Of course, both of them are important. I get that. Both principles are equally important. However, if you cannot help somebody or did not help someone, make sure you did not go out of your way to harm somebody. So that's the point I'm trying to make here. I'll give you an example. Let's say that you had a client who needed pain management, and my job was to assess the patient for pain management, and I didn't. In other words, I did not prescribe medication or did not give medication or offer medication or didn't do anything to help my client. That means I did not practice the principle of a beneficence. I did not help that person. Here, what I did was, I knew that my client was in pain, and I not only I didn't help the patient, I actually went out of my way to harm my patient. I either intentionally gave incorrect medication or prescribed incorrect dosage, or whatever the case is. I ended up harming my patient. In my opinion, that is a far more dangerous, and we should avoid harming than the fact that I just didn't help. So I hope I was able to make that clear here. Okay, and then of course, the next principle is ethical concept, justice. Justice means to be fair with your clients, regardless of their age, gender, sexual orientation, religion, culture, ethnicity, and so forth, right? Socioeconomic factors. We should, or even a clinical diagnosis, hip replacement versus I don't know, drug use, a disorder. We should treat everyone with a fairness. Okay, and veracity is very important concept. Duty to be always truthful, be honest, be transparent with our client. If a client asks you a question, don't just talk in a circle. Give them the right answer, the correct information. Even if you don't know the information, it's okay to say, well, let me take a look. I'll look it up and I'll get back to you. One example that I gave, especially when I do inpatient rounds, if I tell my patient I'll be back in, let's say, 5 minutes or 10 minutes, make sure I do go back in 5 minutes. If I'm not able to go back in 5 minutes, I should not promise that. And then I should say something along the line, you know what, I don't know when I'll be able to come back, but I promise one thing, I will see you before I leave today, before I'm done making rounds. At the end of the day, I'll see you. But if you said 5 minutes or 10 minutes, then make sure you come back. So anyways, try your best. I know it's the schedule sometimes is very tight, and then we sometimes make promises and we are not able to keep up, but please practice this. Your patients will appreciate this principle. And this also applies to the fact by giving a prognosis. Never ever overpromise that everything will be okay. Those are non-therapeutic statements. You don't know if everything will be okay or not, so don't just sugarcoat. Simply say, I don't know, but here is the medication that will minimize your symptoms, and then be honest, transparent with your patients. Okay, next I'm going to introduce, well, it's not a necessarily new term that you have heard, but hopefully just a recap, negligence versus malpractice. People, often get confused and ask what exactly is the difference. To be honest with you, yes, there's a difference, but I don't think there's a big difference. In other words, negligence, in generally speaking, is that you failed to follow that standard of care. Like there was a negligent was done, right? If as a clinician, if we were not able to follow the standard of care, and by doing so there was some harm that was done, so that negligence. Now medical negligence, or when we as a professional, healthcare professionals, when we did not follow the standard of care, we can fall under malpractice. So malpractice is really for professionals, if you will, for you and I. And sometimes there honestly isn't any difference between a negligence and malpractice. But the point here is, in order for someone to really make that statement that this is a case of a malpractice, you have to meet 4 of the following elements. And number 1 is you actually had a legal duty to provide service to that client. So either there was you accepted that client, or you were on duty, that was your shift, or that was patient was assigned under your care, or there was some kind of a payment accepted. So there was a clear relationship, provider client relationship was established. It was your responsibility, duty to provide service. So that's the first criteria. Second is there has to be a breach of duty. You failed to provide that service. There was a clear breach. So that's second. Number 3 is a proximate cause, which means that the breach of that duty is the cause of client's injury. When I say your injury, this is coming from the patient standpoint of view, so you can say client. Whatever that injury is, that injury resulted from a direct action of that breached of that standard of care. And number 4 was damage. The client has been substantially injured as a result of that breach in the standard of care. So in other words, not every mistake, if somebody made a mistake, cannot fall under malpractice. Somebody has to prove that. But you have to be very, very careful, right? Some things can highly be subjective. So when you when you take care of a client, be very, very careful that you have not just a legal responsibility, but of course moral responsibility as well. There's a standard of care that we should follow. Okay, next ethical term is defamation of character, when shared information is false, and it can actually ruin someone's reputation. So that's a defamation, and then it can be done either orally, verbally, or in writing. So oral would be slander and libel is written. So be very careful when you write a progress note. Be very objective. Don't show your personal emotions when you document a patient's behavior. Be very, very careful. And same thing with colleagues. We have to be very, very careful when you write, when you email someone, anything that you document. So verbal is when you're talking about either patient or a coworker, maybe in a cafeteria, in the hallways. Be very, very careful. And this is something that you were writing either in a progress note or emails and so forth. Okay, HIPAA, we know very well what HIPAA is. Tort is a violation of a law. An individual has been wronged. And then you can have two of the subtypes, if you will, assault and battery. Assault is a fear or apprehension that an individual will be touched without consent. So when you make a statement that if you don't take antipsychotic medication, I have to give you IM injection. You don't want that, do you? That's assault. You are threatening someone. So be very, very careful with the way we explain things. Now, that might be a true statement that if the person, especially if they do not have a right to refuse, if they're refusing a medication, you might have to give them IM injection. But it's the way you say it. You have to be very, very careful. There's a difference between threatening someone versus giving information. For example, I can tell the client that, you know what, if blood sugars are not controlled with metformin or, I don't know, some other medications, sulfonylurea or Januvia, whatever, we might have to start an insulin. But I will not make a threatening statement that if you don't take metformin, if hemoglobin A1C is still high, I just have to start you insulin. You don't want me to do that, do you? So be careful with the way we say it. Now, battery is when you ended up touching someone. So in the first option here, you just made a statement that individual will be touched without consent. In other words, I'm going to give you injection. And here you ended up doing it. So once you touch a patient, when you put a hand on it, you gave suppository without permission, or you gave injection, or whatever the case is, then that will fall under battery. So then the term is informed consent. That simply means that you need permission. So anything that we do should have informed consent. Now, consent doesn't have to be in writing, by the way. It's not that you need signature every single time. It depends on the procedure, depends on the skill. Needless to say, some invasive procedures will require written consent, for example, surgery, big procedures, and so forth. But some procedures may just require a verbal consent. For example, if you give injection, you can say, is it okay? You ask permission for vaccine, right? Dressing change and so forth, right? Those are just verbal consents. So be very careful. Now, in case of emergency, or if the client is clearly either harm to self or someone else, then you may not either have a time, or you may not be required to get the consent at that time. For example, if the client is, let's say, aggressive, either agitation, maybe hallucination, or thoughts of harming self or other, and you have to restrain that person, at that time you may not have time to get the consent, or patient is not going to give you consent. So those are the options. Of course, that's exception. Now, when we talk about obtaining a consent, the question usually comes up, is the client competent to make that decision, or sign that document? Now, be very, very careful to use the term competency. Competency is actually not a medical term. It's a legal concept. And you know that, and I also know that you and I, both of us, are not attorneys, right? So this is not a law school. We are clinicians, so we can only use a medical terminology, but not necessarily a legal term. So be careful when you say patients are competent. To determine if a client can make a reasonable judgment and decisions regarding health is a part of competency, by the way. A client is considered competent until a court rules the person to be incompetent. In other words, only court decision can rule out that that rule in or rule out that the patient has a legal capacity to make decisions or not. Client should be considered competent unless you have in writing from the judge that this client is incompetent. If a person is deemed incompetent, then someone else should be appointed to make decisions. So you have a guardian, either third party, like either parents or family members, or sometimes you have someone else, like a client will be conserved. So someone else will make decisions on client's behalf. So as a clinician, we assess the client if they have a capacity to make medical decisions. So start using capacity term when you document instead of saying patient is a competent. So sometimes I get a phone call from a nursing home social worker. They really want to know if the patient is a competent to sign these they have a property or bank account, and spouse is asking if they can sign these documents. And let's say you have a client with a dementia, Alzheimer, or some mental illness, and so I tell them, well, I can assess the client from a mental status exam standpoint of view if the client has a capacity to make a medical decision. So I will say, in my opinion, client can make medical decisions, but I'm not saying that that client can make legal decisions. That needs to come from the court if they are able to sign a contract, sell a property, buy a property or not. So be very, very careful with that. Okay, so that was a terminology. So when we talk about rights of psychiatric patients, let me ask you a question. Do you think we can force a client into a hospital if their behaviors are bizarre? So think about it, bizarre behaviors such as maybe hallucination, delusions. Can we force that client to go to the hospital and get help? Well, hopefully you're saying no, we cannot. That's the right answer. But what if I tell you that can you force a client to the hospital if their behaviors are bizarre and also harmful? Then the answer is perhaps yes. So we'll talk about in a few minutes when can you force these patients to seek a treatment. At what point do we do that? Needless to say, these clients are at very high risk for mistreatment and abuse. Any client who falls into special population, either child, adolescent, pregnant women, geriatric clients, homeless population, clients in the prison system, clients with substance use, clients with some kind of a mental illness, they are at higher risk for mistreatment and abuse than other population. What rights do they have? Generally speaking, what rights do they have? So think about it for a second. I'll give you the answer in a minute. And under what circumstances those rights can be denied, and more importantly, what specific human rights can be denied to a person who has a mental disorder? Well, generally speaking, all patients have the same rights. A person with a mental illness has the same right as someone admitted for chest pain or someone recovering from appendectomy or whatever the case is. So please understand that all patients should enjoy the same rights. There are some exceptions to the rule, of course. Generally speaking, patient has right to privacy, right to have access to a phone call, mail, right to selected treatment. So client should be able to have a conversation with you that no, I do not want this type of antipsychotic. I want this one. I don't want Zyprexa. I want risperidone or whatever the case is. That doesn't mean that we have to do everything that patient asks, but at least acknowledge and ask one question: should I do that? Whatever they're asking, is that a reasonable request? If the answer is yes, it's not out of the ordinary request. It's within the standard of care. Then why not? And always let your client know that they are the captain of the ship. It's all about them. We should never come across as being on a power trip, if you will, right? Okay, so the clients do have rights to refuse medication. This is generally speaking, if you have, especially for outpatient, right? most of the clients on outpatient will have a right to refuse medication. We'll talk about exceptions for inpatient psychiatry in a minute. Your clients have a right to get a second opinion. They have a right to access to attorney and so forth. So I'm going to talk about situations where we take those rights away in a minute. But let's say you have a client who's admitted to the hospital, maybe in the ER, maybe on med-surg or psychiatric hospitals, and then there will be a time when a client is in danger or someone else is in danger because of their mental illness, and then you might have to restrain your client. So remember, now we are taking that right away from them, right? All patients have a freedom of movement. So anytime you either manually do something or chemically, like with the medication you prescribe, that can be seen as you're restricting someone's freedom. So that would be restraint. If you have to restrain a client, always use the least restrictive method. And when we restrain someone, we have to initiate it one-on-one. Someone has to physically present in front of the patient. We never use restraints as a PRN. Otherwise, in other words, you cannot have open-ended as needed restraints. There has to be a reason at that time, and never use restraints as a punishment. Never for staff convenience. An RN must obtain order within 1 hour of placing patients in restraints. Please follow the wherever if you ended up working in inpatient facilities, follow their facility protocol for these. But rule of thumb is for age 18 and up. So in other words, for adults, these restraining orders are good for 4 hours. And then for children, adolescent 9 to 17, so about teenagers, they're good for 2 hours. And for minor, anyone at less than 9 years or below, these orders are only good for 1 hour. So 1 to 4 based on the age. They're age specific, so I'm sure you know why. So okay, IM medication. If the IM drug is given, which happens, pretty often, to be honest with you, especially in psychiatric facilities or maybe in the ER and so forth. So if you if the physical restraints are not good enough, remember I said you have to use the least restrictive method first. So least restrictive would be, of course, maybe just to restrain one wrist or one arm, one extremity, right, instead of both. That would be higher restrictive method. So and then keep going down the list. But if you have to use IM injection, that becomes a chemical restraint. So it's not easy, sometimes not possible, to undo the chemical restraints, right? It's easy to undo physical restraint, right? You can just undo it. But if you have to do a chemical, which is not least restrictive, then the goal at that time should be reassess and perhaps remove the physical restraint, because now otherwise you have a client on two restraints, a physical and a chemical, and sometimes you might need it, but you have to justify that. Otherwise it's a double restraining. And of course a nurse will check every 15 minutes. Patient should be on a charting on behavior, and the question that staff should be asking is, what are these clients doing, or what are this client who's under restraint, what are they doing right now? Are they safe? Are they okay? And why are they still in restraints? If you cannot answer this question, like why are they still in restraint, it's probably a time to discontinue restraints. So in other words, you have to justify every 15 minutes why they still need to be on restraints. In every 2 hours, RN assessment must offer food, water, and toileting. These are their rights. So make sure you reinforce that. And needless to say, if you did not follow the protocol, that'll fall under false imprisonment. So be very, very careful when you have to go this route. Everything is time sensitive. Make sure the orders are signed in a timely manner. There's a very good reason. You have done everything to avoid that situation and so forth. Now sometimes restraints are not enough, and you might have to use exclusion method. So exclusions are involuntary confinement in a room or area where the person is physically prevented from leaving. So it's a special room where in the psychiatric facilities where this patient will be placed away from their hallways or their assigned room, if you will. This is used for a purpose of safety or behavioral management, safety of the patient and others, and to manage their behavior. These clients at that time are very agitative, aggressive, risk for harming self or someone else, like a staff or peers. So this room will contain a mattress and a blanket, so basic necessity, usually padded walls so that they do not harm themselves. The entire room has to be very, very safe. There cannot be any hanging device, and no electrical outlet and windows and so forth. So there'll be most of the rooms nowadays have like video cameras so that we can monitor their behavior sitting at the nursing stations. And these clients are observed at all times, and most facilities have abandoned this practice because this can extremely provide a negative I don't know, atmosphere or environment for these clients. So this is not a part of a milieu at all. This is not a safe, I mean, yeah, it's a safe in a way that at that time you need it, but overall the experience can be very negative. I'm actually proud to say that we're trying our best not to use this. Some facilities do not use this at all, and some facilities are using it less frequently. It really depends on the demographic of that facility, and I do know, I'm aware of facilities that use this a lot. So again, but just understand that overall the concept is that we should not use this if we don't have to, of course. And outcomes may be worse if used. Long-term outcomes. Okay, so let's talk about involuntary hospitalization. Remember earlier I asked you, can you admit a client without their permission if their behaviors are harmful? And the answer is yes. So there's an act that we need to talk about, LPS Act. So according to the guidelines, these are the guidelines that will give us a criteria so that if the patient is meeting, we can admit these patients against their wish, if you will. So there are three grounds for involuntary confinement, admissions. And number one is, and you need to know this concept very well. Number one is a danger to self. Are the client making statements of harming themselves? So suicidal, right? And sometimes we write SI. So SI as suicidal ideation. Number two is danger to others. So that would be homicidal ideation, HI. And number three is they're unable to take care of the basic needs, their basic ADLs, to provide food, clothing, shelter. Here's the keyword: due to mental illness. So in other words, you can't have just a client with I don't know, let's say for any other health issues, let's say for COPD or dementia or Alzheimer, that is not considered as a mental illness, for at least for this criteria, right? So if you have a client who's a gravely disabled, they must have a mental illness, not a physical illness. So you cannot have some kind of cancer, let's say, or HIV or some other respiratory issues, and then you're gravely disabled. You cannot force that client. You cannot apply this principle. I guess that's the point I'm trying to make here. So GD is how we express this. Okay, so a typical scenario would be, you can say 27-year-old male, with either SI or HI or gravely disabled, something like, so you'll see this terminology a lot, presented with psychosis. or whatever the symptoms are, and then you're setting up your HPI in your case presentation that this person is meeting the criteria. So just remember, they don't have to meet all three, by the way. It's one or the other. Only one criteria is required. Most of the time, these clients who are being admitted in psychiatric facility, they usually have more than two elements, and most of the time all three. Okay, so who's authorized to take or place an individual into custody or on hold? Well, a peace officer can do that, an RN designated by the county, or member of the mobile crisis team, licensed professionals, anybody who's designated by the county can place these holds. I'm going to talk about this. This is a nice overview of LPS Act. We're going to start with the 5150 status, and then we're going to go all the way down. So I'm going to bring the slide again. We'll talk about it one item at a time, but this is a nice summary or algorithm, you can say, of LPS Act. So let's start with the 5150, and then we will go down these two branches, if you will. Okay, so 5150 is a 72-hour hold to a psychiatric facility for evaluation. Remember, you're trying to evaluate a client because they either have SI, suicidal ideation, homicidal ideation, or they're gravely disabled. These are the three criteria, and you pick one or the other or all three, it doesn't matter. As long as you're meeting the one criteria and they have a mental illness. This is secondary to mental illness, right? So you can place them for 72 hours, up to 72 hours. You may be able to discharge them within 5 hours, 10, 12 hours, but it's up to 72 hours. It's a time and date sensitive, so it does expire. Okay. Now, what happens if after 72 hours they're still not stable and you want to you want to keep them longer than 72 hours? Well, 5150 is going to expire, so you cannot keep them under 5150. And if the patient still need help, then the client will enter into 5250 status. This is a 14-day hold for intensive treatment. This allows a qualified officer or a clinician to involuntarily confine that individual who deemed to have a certain mental disorders, so psychosis, bipolar, whatever the case is, for up to 14 days, followed by 5150. So you did 72 hours, now another 14 days. This is also date and time sensitive, of course. The hold is placed by a psychiatric staff who determines a person deemed to have a mental disorder that makes them a danger to self or others or gravely disabled. In other words, you still have to meet the previous criteria. Okay, so documentation is very, very important. The person needs more than 72 hours for treatment. So you're making a statement, this person is still at have thoughts of harming someone else, or they're gravely disabled and they need more than 72 hours because you already took 72 hours, right? And they need more than that, so up to 14 days, then you enter 5250 status. Now, if the person is not a danger to self or others, the person cannot be held if there are responsible family members, friends, or others who are voluntarily willing and able to take care of the person. In other words, if the person does not have thoughts of harming self or someone else, and the family member says, well, I can keep my grandson, I can take my son or my spouse home, then they're really not qualifying or meeting the criteria for 5250. So be very, very careful with that. So that's why collateral information is very important. Always involve your social worker and get some family background information, support system for these patients. Okay, so this is very important part of 5250. Certification of hearing must be held within 4 days of the initiation of 5250. Hearings are scheduled by the office of the counselor in mental aid and take place in the hospital. The patient doesn't go out, patient stays there, and hearing will be held at that psychiatric facility within 4 days. If a hearing did not take place, that hold is considered illegal. You have to open the door for that patient. You're not able to keep them if they did not go through certification of hearing. So it's very, very important concept. And usually we are very good at it. And then I have seen actually one time where somehow a patient did not show up on the schedule for certification of hearing, and then we had to open the door for that patient, because that would be considered illegal confinement otherwise. So this is their right. You have to do that. Okay, so what happened next? Well, if the patient is continues to be in danger, SI, HI, or gravely disabled, we can apply for recertification of intensive treatment during 14-day certification. Patient attempts to threaten suicide, so they're still in danger. An additional 14 days can be given. Now at this time, no hearing will take place for the hold. So that's that. However, a patient can request a writ of habeas corpus at that time. This is a legal request by the hospitalized person requesting a place from the LPS facility. The individual will then be allowed to present the case in court with the help of a public defender as to why he or she should not be on conservatorship and or in the hospital. In other words, you don't have to offer this. You do not have to offer this. Patient has a right, and they can request. And we have had patients. I remember one time patient wrote me a very long, lengthy, well-written letter why he believes that he does not belong. The letter was written so beautifully, and I told the social worker, you know what, it seems like he has a point, so let's arrange that that meeting, if you will. So it happens, here and there. Okay, 5270, 0.15, additional 30-day involuntary psychiatric hold over and above that of a 5150 or 5250 hold in the state of California. Remember, these sections are just for state of California. Other states may have a different terminology. So that's additional 30 days here. And then of course you have a post certification for dangerousness. Facility may petition the court to require the client to remain in the facility for further treatment, but this treatment cannot exceed more than 180 days. Patient has a right to represent by an attorney and to a jury trial. They always have a right to be represented by attorney. Reese hearing is a capacity hearing that may be held to determine if a patient can refuse a treatment medication. So if you believe, again, HI, SI, suicidal ideation, HI or GD is required, and then you believe that the symptoms of psychosis are very heavy, aggressive, and the patient should not have a right to refuse treatment. Patient is refusing treatment, and then you want to be very careful. You can actually request for this rights to be taken away, if you will. The hearing is conducted by a hearing officer at the facility, and they will determine if the patient has a capacity to refuse medications or not. So if that is determined that they do not have a capacity, remember this is legal term now, right? So then patient cannot refuse the medication, and then you can actually give them, you can restrain them or give IM injections or whatever against their wish. And most of my patients, actually all of them, do not have a capacity to refuse medications. So in other words, they cannot refuse. But that doesn't mean that we advertise this and we remind them every single day. I mean, I allow them to have one bad day as long as they're not harming anybody. But if they refuse 3 times in a row, then yes, then we do initiate that. And then TCON is a temporary conservatorship where a patient is not able to make a decision. Remember, I told you, if the patient doesn't have a capacity, if patient is incompetent according to the court, then somebody else will have to make that decision. Now we put them on a TCON, a temporary, so it's good for 30 days, and it can be initiated at any time when the client is on hold, but usually occurs during the time in which patient is on a 14-day hold for after 5150 or so. Okay, so here's a recap. So we talked about 5150 here. So let's say the patient is no longer danger to self, dangers to other, or gravely disabled. Then what we can do is actually we have done a few times where we tell the patient, well, you came in, let's say 2 days ago, and yes, things are looking much better, but you can continue to stay here and then get some treatment, get some help, so we can switch to voluntary status. And if the patient says okay, then we can keep them and treat for a few more days if we have to. Now, I do want to make a statement here actually, and the opposite is also possible. In other words, sometimes what happens is patient comes in on a voluntary status. I have seen patients where the patient comes in, check, and they say, I am not feeling well. I feel like I'm gonna kill somebody, or I'm gonna harm myself. I feel like I'm gonna walk into to the traffic, and I just want to jump off the bridge, or whatever the case is, right? And I need help. They come in as a voluntary status, and during assessment, if I see that they're hallucinating, or the burden of the disease is very high, or they have thoughts of harming themselves, or they have a plan, then I can put them on 5150. Let's say we put them on 5150 status. Now, because they walked in on a voluntary status, but the minute we change their status from voluntary to 5150, that does not mean that they can walk out now. And sometimes we come across this issue. The patient will argue the next day. They'll say, well, but you can't keep me because I did not come on a 5150 status. I came voluntary. And we say, well, yes, you did, but we changed the status from a voluntary status to 5150. Now you cannot. We can hold you up to 72 hours. So be careful. So be careful. What the patient tells you, and then be very, very careful when you give this news. Make sure you are safe and the patient is safe. So we can change that. The goal here is make sure the patient is safe, right? Okay. So let's say that with the 1550, there's no danger to self, others, or gravely. You can discharge them. Either discharge them or switch to voluntary. Now, if after 72 hours they're still at risk, either to self or to others, or they're gravely disabled, then we can initiate a 14-day, right? So 14-day, but you must have a hearing within the 4-day. We talked about that, right? That's a right. That's their right. So 50 to 50. Then question is, are they still danger to self, danger to other, gravely disabled? If they're danger to self, you can get additional 14 days and so forth. Now, if they're danger to self, after 31 days, there's nothing you can do. At that time, you either discharge or switch them to voluntary status. In other words, the principle is nobody can stay at a danger to self status more than 31 days. So that's the principle. Keep that in mind. Or it's actually a law, not a principle. So danger to other, that goes for another 180-day hold. And are they still dangerous to other? And that other person could be, spouse or parent or roommate and stuff like that. Can apply for a renewal of 5,300 here. So this is where I want to spend a little bit of time here with the gravely disabled. So look at that. Danger to self expires after 31 days, but look at here. If they're gravely disabled, of course we get 30-day, and then we can get TCON if they are not able to make decisions, not competent. But then TCON, if they're still gravely disabled, then we can get, even though we say they're permanently conserved, but it's really like on a yearly basis. You get conservatorship for 1 year, and we can continue to renew that we have had clients who have been on this process for the past 5 years, 10, 15 years. So that can go on and on. So even though we don't call that permanent, but it's on a yearly basis, and it's a paperwork that we have to fill out, and then this continues under gravely disabled. All right. So, okay, well, there's a slide for that. Once a TCON, the patient is no longer legally on hold, but it's a temporary, okay, I think we talked about that. So permanent, even though it's not a permanent, but it's only up to for 1 year. But okay. Good cause, denial of rights. This can only be done by a professional in charge who has a good reason, such as injury, serious infringement or rights of others, and or serious damage to the facility, and there's no less restrictive way. Once the imminent danger no longer exists, a patient right must be, well, that makes sense. You have to restore those rights, and this must all be documented in medical record. The point I'm trying to make is you can temporarily deny those rights, right? These are denial of rights, but and they are done based on a principle of a good cause, and they're temporary. So the patient, especially in a psychiatric facilities, if they, let's say they were supposed to attend a group and they got in trouble, or they had a fight, an argument. We do that in my facility. We can say, well, you were supposed to go out for, let's say, for outing, and then now you can't because you hit somebody yesterday, right? So we can take that movement of freedom, if you will, away from them. So it's a part of that program where we are teaching them these skills, if you will. Okay, when we talk about HIPAA, there's one principle that I believe is very, very important for us to understand. So, um, so this is an exception to the law of privacy and confidentiality. You know how with HIPAA we cannot share patients' information with anybody. The exception is tariffs rule. Um, so there was a famous case in 1974. Tarasov versus the regent of the University of California. So what happened was that there was a young a graduate student at UC Berkeley who fell in love with another student, university student. So they would meet on a weekly basis, and so they had an affair. Um, so this guy, he thought that the relationship was serious, but the girl here, the woman, she told him that she was not interested in this relationship, and the guy here, he did not take that rejection very well. So he became very upset and angry at her, and he began to stalking her, and started recording some of their conversation, and started analyzing her behavior to figure out the cause of the rejection. Um, Now, very quickly, he became very depressed, and he started neglecting his health, and overall, this has a very negative impact on his physical health and mental health, and on his education as well, of course. Now, when the college was on a break, on a vacation, his roommate asked him to start therapy, and he would contact a therapist at the campus at the university. So he contacted a psychologist, and he told the psychologist that he has ideas or thoughts of killing his former girlfriend when she returns back from vacation. Now, um, the um, the therapist at this time, who the psychologist who was treating this young man, his own wife at that time had recently attempted to murder her child, and attempted suicide. So he also, the psychologist also had a significant stress in his life. But anyways, what happened here was that the, um, the student was diagnosed with a severe schizophrenia, and his psychologist recommended inpatient treatment as he had ideas to harm his girlfriend. Um, Now he was picked up by the campus police, but then very quickly he was released because he promised to stay away from his ex-girlfriend, and he appeared to be very rational. In other words, he was alert and oriented, and he made sense at that time. So he was never hospitalized. When when his girlfriend came back from vacation, he saw her again and he stabbed her to death. So she dies, and the young women and the girls' parents, they brought a lawsuit to the psychologist, psychiatrist, the university, because they did not warn the girl or her family of this danger. Now, the defendants argued that warning the women or her family would have breached the professional ethics and violated the client's rights to privacy. But the California Supreme Court ruled that mental health professionals, they have duty not only to a client but also to the individuals who are being threatened by the client. So that really opened up, a new set of rule or law, if you will, that as a healthcare professionals, we have to ask this question: do you have a thoughts of harming someone else? If the answer is yes, then who is this person? Do you have a plan? And then we are required by law to notify that person. So wherever you work at, identify how this works. Who contacts the family. Is it a social worker, case manager, who, or is it you? Whoever the case is. So make sure you're very, very careful with this. Okay, how can you avoid liability in general? Well, know your clients very well. Make sure you know what are they telling you. So history is very important. Effective communication: use SBAR, use a very good SOAP note format, objective information. Involve other people. You don't have to be hero. Don't do everything by yourself. Involve IDT, involve family members when you make important decisions. Very good documentation. We talked about that. Offer options, and can we do this, do that? Involve your patients and document all that, and follow standard of care and follow facility policies. During the lawsuit, one thing that should be doing is that, well, I don't know the facility policies, but I remember I followed that, whatever that policy was, and print that out and say, well, this is all these 25 steps were done when I saw that patients. Practice within your scope of practice and level of competence. Make sure you're up to date. Make sure you attend those continue education seminars, training, and stay within your scope of practice. Follow standardized procedures and facility protocol. Very, very important. It's okay to ask for help. It's okay to consult. You might have to consult with a neurologist or maybe some other academic centers for further treatment. So it's okay to do that. We encourage you to do that. All right. So next topic is, now we are changing the topic altogether, is a criminal process, criminal judicial process. And we're going to talk about a forensic. Now, when you have a client and clinician's relationship based on a crime committed, the process revolves around investigational aspect of the interaction. So what happened, what type of crime was committed. First thing we do is, once the individual who has a mental illness, some kind of a mental illness, and they have alleged crime, the individual is tested for a fitness to stand trial. We determine that, is this client fit to stand for that trial? Yes or no question. Unfit to stand trial: a person is found to be unfit to stand trial if he or she is unable to understand the nature and purpose of the proceedings or to assist in the defense. This person is sent to hospitalization in a forensic mental health facility to become fit to stand trial. An individual cannot be unfit forever. If a fitness cannot be attained in 1 year, a hearing is held. Okay, so the point here is, You have a client who has alleged a crime and has mental illness. So the first question is this person fit to stand for trial? For example, let's say you have a client who has a depression and he killed his roommate or spouse or parent. Is he fit to stand for trial? If he's fit, he will go through the normal procedure, right? If not, he will get 1 year. He will be sent to a hospital in a forensic unit, and he will stay up to 1 year to get treatment to treat that bipolar depression, schizophrenia, psychosis, whatever the underlying mental illness was. But after, nobody can stay on this unfit to stand trial forever. Within 1 year or after 1 year's hearing is held, and then decision will be made. First is not guilty by reason of insanity. This is if the person is judged unable to distinguish right from wrong, or was unable to control his or her actions at the time of alleged crime, the person is declared NGNR. So the decision is based on the principle of fairness. Remember, we talked about that in the beginning, those ethical principles. It is not fair to hold a person responsible if the individual does not know that the action is wrong or does not have control over his or her behavior. These individuals are sent to involuntary hospitalization in secure settings. So let me give you an example, and I know I'm going to oversimplify it. It's far more complicated than what I'm going to say, but let's keep it very, very simple. Let's say you have a client who had schizophrenia, on multiple medications, but a high degree of psychosis, and he comes home and he thought his wife was, or spouse, I should say, spouse was, sleeping with someone else, and he killed the spouse and the other person. And during the trial, it was found that he was hallucinating. There wasn't anybody else in the room besides his wife. There wasn't any second person. He was having visual hallucination, auditory hallucinations, and so forth. So at the time, again, I'm keeping it so simple, I know that, and I'm not an attorney, but I take care of these patients, on a daily basis. So at that time, the client will be considered not guilty by reason of insanity. A person will be sentenced for NGRIs given a date that is equal to the time or sentence to be served if or she had been guilty of the crime. So it's the same number of years the person will spend. Instead of in prison, he or she will be in involuntary hospitalization in a secure setting, of course. Okay, so guilty but mentally ill. And now this is different than what we just talked about. Here, mental illness was a factor, but not to the extent that the person didn't know right or wrong. In other words, yes, the client had bipolar or schizophrenia or depression with psychosis, but at the time they committed that crime, they knew that it was wrong. So we will keep that in mind, that they're mentally ill, but they are guilty, when the previous they were not guilty. Okay. These clients are treated in jail. Needless to say, both clients will get a treatment, right, for the mental illness, because both of them have mental. The difference would be the setting. The first one that we did, we talked about, they will be in the hospital setting, but these clients, because they're considered guilty, they will be treated for psychiatric illness in the jail. And before, of course, we release either of these clients, every effort is made to ensure that these patients will receive a proper follow-up care. Very, very important concept. Follow-up care in the community, and close monitoring for parole staff. All right, to make my point, I gave you a famous example. I'm sure you have heard this before. John Hinckley, who attempted to assassinate President Ronald Reagan in 1981, he was found with not guilty due to reason for insanity. So take a look at this case, and then hopefully this will help you to understand the concept. All right, so I'm going to ask you one last question here. So what do you think? Insanity defense provides a loophole through which criminals can escape punishment. Is this statement true or false? I'll give you maybe 30 seconds. You can pause this and think about this statement. And the answer is false. There are many misconceptions about the insanity plea. People believe that the insanity defense provides a loophole through which criminals can escape punishment. However, in reality, the insanity defense is extremely difficult to use, even in the case of severely ill individuals. So despite the popular belief, the insanity defense is used in less than 1% of criminal cases. So just keep that in mind.
And I think that's all I have for now. Thank you so much for your time. If you have any questions or need me to clarify anything for you, just reach out, email me anytime. See you next time with a new topic.